So imagine undergoing a really painful, super expensive surgical procedure to physically alter your body.
Right.
You go under the knife, fully expecting that this change is going to just unlock a completely new level of confidence, comfort, and physical satisfaction.
Naturally.
Only that you heal up, you step out into the world, and you realize your physical distress has actually gotten worse.
Today, we are diving into this really fascinating, almost totally counterintuitive medical paradox.
It really is. I mean, it completely challenges this core assumption that most of us hold,
Yeah,
right?
exactly.
We are so conditioned to treat the human body like essentially a complex piece of machinery.
Like a car or something.
Right. So if something isn't feeling right, or if intimacy becomes uncomfortable or just unfulfilling, our immediate instinct is to look for a mechanical failure.
Which makes sense on the surface.
It does. We assume we need to swap a part, tighten a bolt, or, fundamentally change the anatomy to fix the problem. Right. But the vast array of clinical data we are looking at today for this deep dive suggests something entirely different.
Completely different, yeah.
And we are pulling from an incredible cross-section of research here. We've got guidelines from NHS Scotland, massive data reviews from the National Institute for Health and Care Excellence, which is commonly known as NICE,
Right.
plus clinical trial data on pelvic floor dysfunction, and some really deep insights from leading psychosexual therapy centers in the UK, like Tavistock Relationships and the Lyon Center.
It's a huge stack of sources.
It really is. And they're all converging on one highly complex question. Can satisfaction improve even if anatomy changes little?
And it's a question that it forces us to look at this undeniable tension between our physical tissues and our psychological state.
Definitely.
We're constantly trying to figure out if our psychology, our self-esteem, our relational security is actually the primary driver of our physical reality.
Rather than just the raw physical dimensions of our anatomy.
Yeah.
And to really unpack how that dynamic works, I think we have to start by looking at how people instinctively try to force satisfaction through physical alteration.
Yeah, we have to look at the surgical instinct, and honestly, the data here is just staggering.
Let's hear it.
So if we look at the statistics provided by the British Association of Plastic, Reconstructive and Aesthetic Surgeons, or BAPRES, it's pretty wild.
Okay.
Looking at the hospital episode statistics for the NHS, they recorded a 5-fold increase in labial reduction procedures over just a 10-year period.
A 5-fold increase.
Yeah. In the year 2010 alone, there were over 2,000 of these operations performed just on the NHS.
2,000 surgeries in a single year just in that one system. That is a massive surge.
It's huge.
Why the sudden rush to alter this specific anatomy? I mean, what's driving that?
Well, the clinical umbrella term for this is female genital cosmetic surgery, or FGCS. And when you look at the NHS Scotland guidelines, they actually outline the motivations patients give during consultations.
Okay, so what do they say?
Some patients do report perceived functional discomfort, say, like chafing during exercise.
Right.
But largely, the primary drivers are a desire to improve appearance and to increase self-esteem.
Interesting.
The guidelines specifically note that there is this immense, pervasive societal pressure to appear, and I'm quoting the clinical text here, neater, or to conform to a highly specific, youthful look.
Wow. So we are talking about individuals taking a scalpel to perfectly healthy functional tissue, largely because of external psychological pressure.
Exactly.
I mean, it sounds like people are trying to tune a guitar that's already perfectly in pitch just because they saw an ad saying it should look a certain way.
That's a great way to put it.
Does changing the tissue actually resolve that psychological weight, though? Does it fix the music?
Well, from a strictly clinical perspective, the medical establishment is raising major flags about exactly that.
Tell me more.
Researchers from the UCL Elizabeth Garrett Anderson Institute for Women's Health conducted a major review, and they point out 2 really massive issues.
Okay, what's the first one?
First, there is incredibly limited long-term data proving these surgeries actually maintain clinical effectiveness or lasting satisfaction.
So the physical fix might not even last.
Right. But second, and honestly more importantly, they highlight this physiological reality. Negative psychological preoccupations actually intensify unpleasant physical sensations.
Wait, let's slow down and really look at that mechanism, because this is where the mind-body connection gets pretty wild.
It really does.
I'm picturing a microphone set up on a stage, right?
Yeah.
If you place it too close to the speaker, you get that agonizing audio feedback loop.
Oh, yes.
It starts as a tiny normal sound, But because the system is hyper-fixated on that exact frequency, it amplifies it until it's a deafening screech.
Right.
Are you saying the brain does that to the body?
That is a brilliant way to conceptualize it, yes. How troubled a person feels about a physical sensation directly dictates the intensity of that sensation.
That is wild.
If you are deeply insecure about an area of your body, if you're constantly checking it, worrying about how it looks, or feeling shame, your brain acts exactly like that microphone.
It just cranks up the volume.
And turns up the volume on every single nerve ending in that area.
Wow.
So a completely normal amount of friction from clothing, or a minor pinch that most people wouldn't even register, is amplified into severe, undeniable discomfort.
So the distress isn't just quote-unquote in their head.
No, not at all. The brain is literally creating a heightened physical reality.
So if a patient undergoes cosmetic surgery on healthy tissue purely to treat that psychological insecurity,
Yeah.
they might wake up from surgery and find the discomfort is still there, or even worse, because that feedback loop is still running.
Precisely. The root cause wasn't anatomical at all, it was cognitive.
Which makes that surgical intervention seem really risky.
It is. And this is exactly why the UCL researchers are urging doctors to be incredibly cautious about performing cosmetic surgery when a patient's genital dimensions fall completely within normal biological variance.
That makes total sense.
They strongly recommend that patients consult with psychological practitioners who specialize in body image before any physical cuts are ever made.
Which raises a really fascinating follow-up. If surgically altering completely healthy anatomy doesn't magically create satisfaction,
Right.
what happens when our bodies change completely against our will? You know, when trauma or aging or a severe illness forces a frontal change upon us.
That brings us to the other side of this complex coin.
Let's dig into that.
So the clinical sources from the psychosexual therapy centers detail the profound physiological changes that can absolutely devastate a person's sense of intimacy.
We aren't talking about minor aesthetic differences now, are we?
No, not at all. We are talking about the physical aftermath of traumatic childbirth, or the surgical removal of breasts or tests due to cancer,
Right.
or severe vaginal atrophy caused by the hormonal cliff of menopause, or the physical shortening of a penis post-surgery.
I mean, these are undeniable, massive changes to a person's physical reality. You can't just think your way out of missing a body part.
You absolutely cannot. But what the clinical data shows is that the ultimate loss of satisfaction following these events isn't strictly due to the mechanics failing.
Wait, really? Then what is it?
The physical change acts as a catalyst for a massive psychological unraveling.
Oh, I see.
The therapy sources outline a specific relational model they call the vicious circle, which maps exactly how a physical change destroys a partnership.
Walk us through the mechanics of this vicious circle. Where does the loop start?
Let's use the example provided in the medical text of a woman recovering from a significant pelvic or breast operation.
Okay.
Step 1. In the aftermath of the surgery, as she navigates scars and a changing body, she feels profoundly less attractive.
That's entirely understandable.
Step 2. Driven by that loss of self-esteem, she does not want to expose her body to her partner.
Right. She hides.
Step 3. She begins to isolate herself, creating physical and emotional distance to basically protect herself from perceived rejection.
I think anyone who has ever felt deeply vulnerable can understand that defense mechanism.
Absolutely.
But the partner is sitting right there. How do they process this sudden wall being put up?
Well, this is where the circle locks in. Step 4. The partner immediately senses the isolation.
But they don't know why.
Exactly. Because the communication has fractured, the partner assumes she has simply lost interest in him, or perhaps that he is doing something wrong.
Oh, no.
So step 5. Fearing rejection himself, the partner pulls back and isolates himself.
Which leads to?
Step 6. The woman sees her partner pulling away, and her original fear is confirmed. She thinks, I knew it, he doesn't find me attractive anymore.
And the loop begins again, spiraling deeper.
Exactly.
It is basically the human equivalent of a bad Wi-Fi connection.
That is spot on.
You have two devices. They both think the other one has gone offline, so they just stop sending signals entirely.
Right, they just give up.
And to an outsider, or even to a doctor, it looks like a physical, mechanical failure. The intimacy is dead, the body is broken.
But underneath, it is a catastrophic communication breakdown disguised as a medical issue.
And if you're listening to this and you've ever felt a relationship inexplicably cool off after you or your partner went through a major illness or an injury, You could probably recognize this exact loop.
Oh, without a doubt.
It's not that the love disappeared, it's that you both retreated into your own defensive corners.
That is exactly the dynamic. The therapy sources emphasize that the true source of the suffering here isn't just the surgical scar or the physical change.
Right.
It is the disconnection. It is the deep, silent mourning of lost body parts, the grief over lost fertility, and the complete collapse of self-esteem.
Which brings us to the most practical question of this deep dive. When a patient walks into a clinic trapped in this vicious circle, experiencing genuine, undeniable physical distress,
Yeah.
how does modern medicine actually treat them? Does it require massive reconstructive surgery to put the body back to the way it was?
Not necessarily. And this is where the clinical evidence reviews from NICE become incredibly illuminating.
Why is that?
Because we can actually compare how vastly different interventions perform against genuine physical distress. Let's look at the NICE clinical overviews for treating a condition called urogenital atrophy.
Before we get into the treatments, let's define what that actually means physically. What is happening to the body in urogenital atrophy?
Sure. It is a condition most commonly associated with menopause.
Okay.
As the body's estrogen levels plummet, the tissues of the vaginal wall literally become thinner, drier, and far more fragile.
Which makes any friction or intimacy incredibly painful.
Exactly. So to treat this, the NICE sources compared two entirely different interventions. On one side, you have transvaginal laser therapy.
Which is a highly clinical, high-tech procedure, right? Where a doctor uses a specialized medical laser to essentially cause micro-trauma to the tissue to force it to regenerate.
Right, very high tech. And on the other side of the trial, you have a simple topical estrogen cream that the patient applies themselves at home.
So we are comparing a space-age surgical laser against a tube of cream.
We are.
The outcome stats here absolutely challenge our assumptions.
They really do.
Because both groups saw massive, life-altering improvements. For the patients who underwent the high-tech laser therapy, 71.9% rated their clinical improvement as better or much better.
Which is great.
But for the patients just using the simple cream, a staggering 82.8% rated their improvement as better or much better.
Yeah, the cream actually outperformed the laser in that metric.
And when the researchers asked the ultimate question, were the patients satisfied or very satisfied with their treatment, both the laser group and the cream group hovered right around 75%.
Right. There was no statistically significant difference in ultimate satisfaction between the expensive high-tech clinical procedure and the basic home cream.
How does a simple cream achieve the exact same or slightly better clinical satisfaction as a surgical-grade laser?
It comes down to the biological mechanism. The cream is essentially tricking the local tissue into plumping back up by directly replacing the exact localized hormone, the estrogen, that the body stopped making.
Oh, I see.
So it treats the environment rather than physically forcing a structural change with a laser.
But we have to be completely fair to the data here. There are times when a simple cream or a psychological shift simply isn't enough.
Right. Oh, absolutely.
There are times when surgical intervention is absolutely necessary and life-changing.
We absolutely cannot dismiss surgery because when a severe mechanical failure occurs, it is vital. The NICE data also extensively covers a major surgical procedure called an infracoccygeal sacropexy.
Which is a heavy clinical term. Let's break down what is actually happening in that operating room.
Sure. This surgery is used to treat severe pelvic organ prolapse.
Okay.
This happens when the pelvic floor muscles weaken so severely that internal organs like the uterus or the vaginal vault literally slip out of their normal anatomical position.
That sounds incredibly painful.
It is. So to fix this, a surgeon uses a specialized synthetic mesh to essentially build a brand new structural hammock inside the pelvis to hold everything back in place.
That is a massive fundamental anatomical change.
It is a major intervention.
And the results from those trials are nothing short of miraculous for the patients.
The stats are incredible.
The clinical data shows that prior to this mesh surgery, 100% of the patients in the trial experienced deep dyspareunia.
Which is the medical term for severe, debilitating pain during intercourse.
Right. But after the mesh was implanted, that number plummeted to just 11.4%.
Wow.
Furthermore, 86.4% of patients reported a massive improvement in their sexual performance.
And incredibly, 100% of the patients in that specific case series stated that their overall quality of life had improved.
100%.
Yes, and they said they would recommend the surgery to others suffering from the same condition.
So we have these two wildly different data points. On one hand, a basic cream works just as well as a high-tech laser. On the other hand, a massive invasive mesh surgery completely transforms a patient's life. How do we synthesize this?
The clinical synthesis here is crucial. Across all these trials, the true metric of success for the medical professionals isn't achieving some idealized vision of, perfect anatomy.
Then what is it?
The metric that actually matters is what they call disease-specific quality of life and the total alleviation of distress. So whether the intervention is a major mesh hammock, a laser, or a dab of cream, the physical treatment is acting as a bridge.
A bridge to what?
It relieves the immediate, overwhelming mechanical pain or dryness, which in turn allows the patient to feel safe enough to reconnect. It breaks that vicious circle.
Oh, I see. The physical fix removes the barrier so the psychological connection can happen again.
Exactly.
The surgery isn't creating the satisfaction. The surgery is just allowing the mind to feel safe enough to experience satisfaction.
You nailed it. The physical treatment is in service of the psychological well-being.
Which brings up a fascinating, almost radical question.
Okay, let's hear it.
If restoring psychological confidence and reducing mental distress are the ultimate goals of all these medical interventions,
Yeah.
what if we skip the physical intervention entirely? What if we target the mind to cure the body?
This is where the profound work of psychosexual therapy comes into play.
Let's talk about that.
Our sources from leading centers like Tavistock Relationships and the Leone Center detail how they treat incredibly severe, physically manifesting issues.
Like what?
We are talking about clinical erectile dysfunction, severely delayed ejaculation, agonizing chronic pelvic pain like vulvodynia, and a highly complex, yes, it is a severe physical reflex. And these therapy centers treat it primarily through talking therapies, mindfulness, and cognitive behavioral therapy, or CBT.
Okay, wait. I have to push back here because this is where the logic feels completely strained to me.
I get it. Go ahead.
If a patient is experiencing a literal, involuntary muscle spasm that causes tearing and bleeding, how on earth does talking to a therapist or filling out a cognitive workbook fix an involuntary physical reflex?
It sounds wild, I know.
It sounds like telling someone with a broken leg to just think positively.
It is a completely valid skepticism. To understand how a conversation cures a muscle spasm, we have to look at the biopsychosocial model.
Okay.
Specifically, a fascinating German randomized controlled trial included in the NICE evidence reviews.
What did they do?
The researchers tested an internet-based guided self-help treatment specifically for vaginismus.
Wait, so the patients didn't even go to a clinic. They just logged onto a website.
Exactly. They did a 10-week internet course from their own homes. There was absolutely no surgery, no lasers, no physical interventions from a doctor.
So what did they actually do for 10 weeks?
The modules focused on psychoeducation, physical relaxation exercises, and cognitive restructuring.
Which is a core tenet of CBT, right?
Yeah.
Where you learn to actively identify and dismantle catastrophic thought patterns.
Yes, exactly. And they paired this with gradual, self-paced physical exposure exercises.
Where they're sitting at a laptop, doing mental exercises, and slowly testing their own physical limits. What were the actual clinical results?
The results were highly measurable. Their female sexual function index, the clinical standard used to measure arousal, lubrication, and pain, measurably improved compared to the control group.
That's amazing.
And their documented fear of physical intimacy dropped significantly.
From a web browser and cognitive reframing, you have to explain the biological mechanism behind that. How does the thought change the tissue?
Because of the fear-tension-pain cycle, CBT literally untangles the neural panic from the physical body.
Untangles it how?
In a condition like vaginismus, the brain deeply anticipates pain. Before anything physical even happens, the brain sends a massive panic signal down the nervous system to the pelvic floor, screaming, "Protect us!"
So muscles brace for impact.
The muscles involuntarily clamp down like a vice. Then, when physical contact does happen, it hits that clamped muscle, causing severe literal pain.
Which then signals the brain, see, I told you it would hurt.
It's a self-fulfilling biological prophecy.
Oh.
Exactly. By doing cognitive restructuring and deep relaxation, you are actively retraining the brain to stop sending that initial panic signal. You are cutting the wire.
So without the panic signal,
The muscles remain relaxed. Without the tension, the physical pain diminishes entirely. The anatomy functions perfectly, even though the anatomy itself wasn't surgically altered.
the software update completely fixed the hardware glitch.
That is staggering, right?
It perfectly echoes a quote from the Leone Center material that really anchors this entire deep dive.
Oh, which one?
They explicitly state, usually, if you can work through the emotional issues, the physical symptoms will also improve.
That is the cornerstone of their philosophy. Tavistock Relationships operates on the same profound principle.
How so?
Instead of treating the patient like a broken machine and hyperfocusing on the physical symptom, they focus entirely on the relationship.
Right.
They dig into what physical intimacy actually means to that specific individual, how past traumas are haunting their present body, and how they communicate with their partner.
They are shifting the focus from how do we fix this broken part to how do we increase your overall sense of satisfaction and safety?
Exactly.
They're treating the human being, not just the pelvic floor.
Which is exactly why massive medical organizations are changing the way they train doctors.
Well, like who?
The College of Sexual and Reproductive Healthcare, the COSRH, now places a massive emphasis on training clinicians in this biopsychosocial model.
That's a huge shift.
It is. In their menopause care courses, they aren't just teaching doctors how to prescribe testosterone or estrogen creams.
Right.
They are explicitly training doctors to conduct clinical interviews that uncover the psychological and relational barriers to satisfaction, because they know that simply handing over a pill often won't fix the underlying distress.
Let's take a breath and recap this incredible journey, because we have completely flipped the narrative today.
We really have.
We started with this widespread, desperate illusion that physically cutting and altering our bodies with cosmetic surgery is a fast track to confidence. The belief that if we just force the tissue to look a certain way, the satisfaction will follow.
But the clinical data showed us a totally different reality. We learned that our negative psychological preoccupations actually act like an amplifier, taking minor discomfort and turning it into severe pain.
And from there, we explored what happens when physical changes are forced upon us. It creates a vicious circle.
A devastating breakdown in communication and self-esteem.
Yeah, that destroys intimacy far more effectively than any physical limitation ever could.
Which ultimately reveals the core truth of this deep dive.
What's that?
Whether you are recovering from a major pelvic organ prolapse with a surgical mesh, whether you are navigating the profound hormonal shifts of menopause with an estrogen cream, or whether you are retraining your nervous system to cure vaginismus through an internet module.
The psychological framework is paramount.
Exactly. Communication, emotional safety, and cognitive reframing are the true drivers of physical satisfaction.
We don't have to view our bodies as machines destined to break. The mind and the body are locked in a constant, beautiful conversation.
Perfectly said.
Which leaves us with a final thought for you to mull over as you go about your day.
Yeah, think about this.
If our minds had the sheer biological power to literally dictate our physical pleasure, to amplify our pain, and to determine our overall satisfaction in something as primal and physical as human intimacy,
Right.
how much of your everyday physical reality, your afternoon energy crashes, your daily tension headaches, your perceived physical limits is being shaped entirely by your psychological state?
It forces us to ask a critical question every time we experience a physical complaint.
Which is?
Are we desperately trying to mechanically fix a symptom, or do we have the courage to look at the thoughts and fears driving the entire system?
A perfect question to leave on. Thank you so much for joining us on this deep dive. Keep connecting those dots.